In our previous video on NSAIDs, I introduced you to 3 types of analgesics: Acetaminophen, NSAIDs, and opioid analgesics. We discussed Acetaminophen and Aspirin Toxicity in the last part of this video. Now, we'll move towards the toxicity of the 3rd type of analgesics, that are opioid analgesic. Now, opioids are commonly used for the treatment of pain and include medicines such as morphine, fentanyl, and tramadol. You can find a detailed video on opioid analgesics on our website. So here I'll just stick to opioid toxicity. Well, opioids toxicity, or opioid toxidrome, can be identified by 3 main symptoms that are coma, pinpoint pupils, and respiratory depression. Well, you can memorize them with the help of mnemonic CPR. While other presentations of opioid toxicity include hypotension, hypothermia, and hypoflexia, which is a condition where muscles are less responsive to the stimuli. They are quite easy to remember, as all 3 start with the letter H. Now, patients who are apnoic means patients with temporary cessation of breathing or in whom the cause for coma is in doubt, for example, possible trauma, should be given naloxone, which is a short-acting antagonist or antidote of opioids. Whereas in patients who are breathing, it is best to just give oxygen and wait, as there are hazards in giving naloxone, as naloxone causes acute opiate withdrawal symptoms, which may dissuade drug users from calling for help in the future. Moreover, naloxone is short-acting, so there's a danger that a patient may wake, run away, and collapse when the naloxone wears off. Therefore, if naloxone is indicated, it should be a large dose. Well, in patients who have iatrogenic, opiate-induced hypoventilation, where one does not want to reverse the analgesic effect, but just the hypoventilation, then this may be reversed by very small doses of IV naloxone. To prevent opioid toxicity, giving naloxone infusion may be necessary with long-acting opiates. Next comes the tricyclic antidepressants, or TCAs for short. TCA include drugs like amitriptyline, imipramine, and doxepin. These are highly toxic in overdose and are the 2nd most common cause of overdose deaths. But what happens during TCA overdose? The toxic effects of tricyclic antidepressants are mainly a result of blockade of fast sodium channels, resulting in membrane stabilizing effects on cardiac and neurological cells. Toxicity following overdosage arises mainly from central anticholinergic effects like respiratory depression, hallucinations, convulsions, and cardiotoxicity. The most common arrhythmia observed in patients is sinus tachycardia as a result of an atropine-like effect. Acidosis and progressive lengthening of the QTc may also occur. A QRS more than 120 millisecond predicts toxicity, and more than 160 millisecond indicates imminent seizures and ventricular fibrillation. The symptoms sound super scary, but most patients require only observation or simple supportive measures, such as oxygen to correct hypoxia and activated charcoal within 1 hour. Prolonged QRS or arrhythmias observed in the case of TCA overdosage are treated with intravenous sodium bicarbonate. Sodium bicarbonate is an effective antidote here as the alkali reduces. The free drug and the large sodium load help overcome the blockade. Convulsions may also result, which may be controlled by intravenous diazepam or clomthiazole. The use of gastric lavage in tricyclic poisoning is controversial because the gastric contents may be pushed beyond the pylorus and increase the amount of drug absorbed. Struggle during lavage may also cause hypoxia and provoke life-threatening arrhythmias, so it may not be wise to administer gastric lavage. So that was about tricyclic antidepressant toxicity. Next, we'll be discussing anticholinergic poisoning and its antidote. So keep watching.